Our next speaker is Dr. David Cohen. He's going to be speaking about what's driving TAVR outcomes and insights from the TVT Registry. Dr. Cohen is currently Director of Clinical and Outcomes Research at the Cardiovascular Research Foundation, based in the city. He's Director of Academic Affairs here at St. Francis. We're very lucky and happy to have him. Previously, he was Professor of Medicine at the University of Missouri in Kansas City and Director of Cardiovascular Research and the Medical Director of Health Economics and Technology Assessment at the St. Luke's Mid-America Health Group in Kansas City. He was also Medical Director of the Health Economics and Technology Assessment Group there. He earned his MD at Harvard Medical School, followed by a Master's in Health Policy there as well at the Harvard School of Public Health. Trained clinically at the Brigham and Women's Hospital in Boston and was a clinical and research fellow in cardiology at the Beth Israel Hospital for 5 years. Dr. Cohen, welcome. Thank you for coming.
Thanks very much, Matt. It's great to be here in person, and I think actually this is a perfect talk to come right after Kristen's, because I think it really is a lot about the expansion of TAVR and what we have learned. And so I'm going to be speaking really about the first decade. TAVR was commercially approved in the United States in late 2011, and so basically we are 10 years into this revolution, and we've learned a lot, and one of the ways we've learned all this information is from something called the TVT Registry, and I'll talk about that in just a second. As Kristen said, TAVR doesn't really need much of an introduction anymore. It was originally just for these extreme risk inoperable patients, but as, again, Kristen kind of led you through, over the past decade, we've done a number of major randomized clinical trials that have shown that compared to medical therapy, this leads to improved survival and improved quality of life. And then compared with surgery in lower risk patients, intermediate and low risk patients, the outcomes so far have been comparable with a much earlier recovery process. So again, those are kind of the main design features and advantages of TAVR. So what is the TVT Registry? The TVT Registry came lockstep with the approval of TAVR. It was created in 2011 as part of this NCD, which stands for National Coverage Determination, which is how Medicare pays for all these things, and it collects data on every single TAVR done in the United States. It has standardized data elements, and really what it's mostly for is for quality improvement, that you can track any given hospital can see how they're improving over time. We can track this on a national level. We can benchmark off of other hospitals to see how we're doing compared to the others. And it's also been a major a source of a lot of research that I'm going to share a couple of studies with you that I think are very, very foundational. And it's also actually led to approval of transcatheter valves for additional indications beyond what they were originally studied in the trials for. So I want to talk about three things over 15 minutes. I want to talk about some of the national trends that we've seen in procedures and outcomes. I want to talk about center volume and experience and how those relate to these outcomes. And then finally, I want to talk about what I think Newell was thinking about, which is how do the two procedures, transcatheter and surgical aortic valve replacement, how do they interrelate and how do they work synergistically to improve outcomes for our patients? So first, we'll talk about some basic trends. What have we learned and what have we seen? So first of all, TAVR has really, exploded. In the United States today, actually, there's a little over 800 centers that are now performing TAVR. When it was first introduced, it was thought that there would be somewhere around 300 centers that were doing this, but nobody imagined how successful the procedure would be. All of the states are doing it, and there's an additional overlap with about 500 sites that are performing transcatheter mitral valve repair with the MitraClip these days. These show the volumes on a national basis. This slide happens to cut off right at the beginning of 2021. The trends have actually continued beyond this, but you can see there has been tremendous growth nationally. And in 2022, I just saw the latest data, about 90,000 transcatheter aortic valve replacements were performed in the United States, including both native valves and what we call valve-in-valve procedures. And over time, as you can imagine, things have changed. So the STS prom, that's how risky it is, how risky the patient is, has continued to come down as we've gotten better at the procedure and as it's gotten approved for lower and lower risk patients. And on the right-hand side, what you can see is the access site. So when we first started doing TAVR, there were lots of use of what is called alternative access, not going through the legs, going through the chest, going through alternative arteries for patients whose arteries were too small. But as the devices have improved, as the doctors have improved, as our imaging has improved, we've become more and more and more femoral access, which is the preferred access. It's the one that works most reliably, is easiest for the patient, and has the very best results. And reflective of all of those changes going on simultaneously, you can see that outcomes have improved. So in the blue bars here, those are the in-hospital mortality rates. When we started in 2012, they were rather high, although we were working on the sickest of the sick patients back then. They have continued to come down, and now in-hospital mortality is right around 1% in the United States, which is, again, remarkable given the age and complexity of some of the patients that are being treated. 30-day mortality is a little bit higher. 1-year mortality is higher yet because, again, these patients tend to have an age of around 80 years. They have lots of things that they're sick from, and we'll talk about this in just a second, but the outcomes have definitely improved. One thing that has been remarkably improved compared to when it was first introduced is the length of stay. You can see here 3 different groups of patients, high, intermediate, and low-risk patients. And for all of them, in 2021, the United States hit the point where the median length of stay for a TAVR in the United States is 1 day. You come in on Monday, you go home on Tuesday. You come in on Tuesday, you go home on Wednesday. The patients are prepared for this. They love it. They only have to spend 1 day in a horrible hospital bed, and the rest of the time they get to spend in their nice, comfy bed at home. So what, we actually, this is just a little diversion into a research project that we completed last year and just presented at the TCT meeting as a late-breaking trial earlier to try to say, well, here's all these improvements in our outcomes. How is that happening? What is actually going on here that is driving all of that? And so we analyzed all the TAVR procedures in the United States, about 160,000 of them done between 2011 and 2018. We looked at several different outcomes, but mostly focusing on 30-day mortality. And what we're trying to do here is to disentangle what are the drivers. Why are these outcomes improving to the degree they have? Is it the patients? Is it the procedures? Is it the doctors? What is the driving all of this? And so what you'll see, the way we decided to do this study is we looked at different, what we call clusters of different risk factors. So we looked at demographics, just age and sex. And then we looked at comorbidities outside of the heart, things like diabetes and kidney disease. And then we looked at cardiovascular comorbidities like PAD and prior stroke, atrial fibrillation. We looked at the devices because the devices have gotten smaller in size and are easier to use. And then we looked at things that don't relate to the devices but maybe sort of intersect with that, like the type of anesthesia. Used to be we did all these under general anesthesia. Now we do most of them with the patients under what we call conscious sedation without a breathing tube, all of those different factors. It was really an interesting study. So first of all, again, you can see here what's happened with the patients over time. So in terms of the age, they've gotten a little bit younger, although they still are quite on the older side. You can see that a lot of the comorbidities, again, as we've gone down the risk spectrum, the comorbidities are getting less, fewer patients with lung disease, fewer patients on home oxygen. And then you can see the access site, which I already highlighted, went from, in the 60% femoral up to 95% femoral, which is, where we are even higher than that at St. Francis these days. The sizes of the arterial sheath, so a 22 to 24 French sheath where we started, that's the size of my thumb. Now we're down to a 14 French sheath, which is about the size of a decent pen. And finally, you can see the use of general anesthesia nationally has gone from 97% down into the 40s, and it's actually a little bit lower than that again today. So that's how the procedures have changed. So what has happened again with the 30-day mortality? So what we're looking at here is, this is statistical. I don't want to bore you with all the details, but basically what you can see is the vertical line in the middle, that's 1. And we're looking at the annual change in the annual 30-day mortality rate over time, and we're adjusting for all these different conditions. And what the main thing to see on this is the biggest jumps in that graph are happening when we add in the device factors, meaning the size and the location of our incision, and then the non-device procedural factors like changing the anesthesia type, use of cerebral embolic protection that Dr. Petrosian is going to talk about in a little bit, some of those factors. So those are the 2 biggest drivers. And when we look at this for 30-day mortality, this is showing the percent of the total improvement over that 8-year period that's explained by these different factors. And you can see here 70% of the improvement in 30-day mortality is explained by the devices and the procedures, much smaller amounts on the patient side of things. But when we get to the 30-day composite, when we look at complications, things like pacemakers, leak, kidney failure, stroke, those things, we can still see a lot of it is explained by the device, but there's that light blue part at the top. And what that light blue part is the part we can't explain because we can't measure it. That's the doctors and the hospitals and the health system. That's what's sort of left over after you account for everything else. So there's a major component of skill, learning, all of the techniques that we've adopted over time. That whole heart team that Kristen was talking about is there. And then when we look at the 1-year mortality, now the device actually plays less of a role. There's a little bit more of a role on the bottom, which is the patients, because the patients are getting healthier and they have less complications that lead to mortality over the year follow-up. But again, still there is a very important contribution of the system, of the heart team, of the physician's skill and judgment that goes into these procedures. So again, I think a very interesting and telling slide that is likely to be replicated as we start to go into some of these newer procedures that you're going to be hearing about today. Second thing I want to talk about from the TVT registry is volume and experience. Now we know, again, in almost everything, practice makes perfect. And it turns out that transcatheter aortic valve replacement isn't any different. This is a paper that was published a couple of years ago in the New England Journal of Medicine, using data, again, from the TVT registry to look at the relationship between hospital volume, operator volume, and risk-adjusted 30-day mortality. You can see the volumes. Again, this is a little bit of an earlier study, but the highest quartile, the highest group of volumes of TAVR in this study was 140 per year. You just heard from Kristen that we do about 550 per year here at St. Francis. So again, quite a difference. On the operator side, the highest quartile was about 70 per year. I don't think there's any operators at St. Francis who do less than 70 a year. So again, I think we're way up on this scale. And what you can see here is how the risk reduction in 30-day mortality on the left is versus hospital volume, and on the right is versus the operator volume. And what you can see is that for hospital volume, it tends to plateau. You get about 150 or so per year, then you get a plateau. So clear relationship there. If you look at the operator volume, again, somewhere around 60 to 70 is where it plateaus in terms of improving outcomes. So clearly, both hospital and operator volume play a major role in the improving outcomes that we've seen. And again, the thresholds for sort of optimizing these seem to be around 200 procedures per year for the hospital and about 70 procedures per year for the operator. What about experience? Well, this study slide here is not about TAVR. This is about MitraClip, which you're going to be hearing about, throughout the day in other settings. Here again, this is an analysis from the TVT registry of patients undergoing transcatheter mitral valve repair, and you can see here that the sequence number, sort of where they are in their learning curve, makes a big difference for. On the left-hand side is the likelihood of success. On the right-hand side is how long it takes you to do the procedure. You can see that there's just this continuous relationship, and I think I just heard that St. Francis just passed its 400th MitraClip. I think I heard that from one of our reps earlier today. So again, we're well out beyond the edge of those curves. Finally, I want to share what I think is maybe the most important insight from the TVT registry, from other studies like this. This is a study I'm going to share with you is from Medicare. But how has TAVR impacted how we treat patients in the United States with aortic stenosis? And this is a paper. There have been several versions of this. Is probably the best one. This is looking at Medicare data, looking at the patients who had either transcatheter or surgical aortic valve replacement between 2012 and 2019, and looking at a number of different factors. How were the procedures being selected? How were the outcomes in risk-adjusted analyses? The first thing that came from this study is you can see, again, what Newell predicted, which is that there's been a big shift in which procedures the patients are having. You can see in the red there is the TAVR curve continuing to go up, and it has continued to go up past 2019. The surgical aortic valve replacement, initially it actually went up very slightly when TAVR came out, but now it's been continuing to decline as we've again started doing TAVR on lower and lower risk patients. But the most important thing here in this graph is the black line, which is showing all aortic valve replacement in the United States. That is, we're treating a lot more patients. We're not just cannibalizing from one another. We are actually expanding the pool of patients who we can treat. So that's point number one. The second one, even more important, is how has that impacted the outcomes? And what you can see here is the all AVR, surgical aortic valve replacement, and then transcatheter aortic valve replacement. And these dots represent the relative risk per year of mortality at different time points or readmission, again, comparing year over year over year adjusted. And what's really important to look at the 30-day mortality. With surgery, it's continued to get better over time. So surgery is getting better during that time. Transcatheter aortic valve replacement, as I already highlighted, because of a number of developments, is getting better over time. But the most important one is on the left, all aortic valve replacement. So when you put everybody together we're better as a team. And I think that really is the message in this, in this slide, because what we can do now that we have two different procedures is we can tailor them to the right patient. So what's happening here is that surgery is getting better, surgeons are getting better, but also because the high-risk patients are being peeled off. The high-risk patients aren't getting surgery anymore. There's no reason to do surgery on a high-risk patient. Send them to TAVR. They're going to do better. They're going to recover more quickly. TAVR is getting better because of the technology, because of the learning curve, all those things together. It's incremental. It's synergistic. We're getting even better, even better. So finally, just to summarize, a couple of key points. As you've seen, over the first decade of commercial TAVR in the United States, our outcomes have improved dramatically. And the main drivers have been innovation, technical and procedural advances, and these are important particularly for short-term mortality. As with most procedures that we do in medicine, operator and institutional experience, along with institutional volumes, continue to play a major role in reducing complications and optimizing efficiency. And despite reductions in the use of surgical aortic valve replacement, the availability of TAVR as an option for these patients has led to significant growth in overall AVR volumes and improvement across the board in both short and long-term mortality for all patients. Really, it's been a win-win, with the big winners being the patients. And finally, I think the availability of these registries like the TVT registry and with detailed clinical data at the population level has really been essential to understanding, all of these insights, and is likely going to continue to drive quality improvement and innovation as the field of structural heart intervention continues to expand more to the mitral valve, more to the tricuspid valve, and other procedures even outside of the valves. Thanks very much.